everyone, and welcome to our EMS webinar. Today, we will be talking about particularities of airway management in tracheostomized patients. I will introduce you to our prestige panel of speakers that will be joining us today in our webinar to talk about what we need to know about tracheostomized patients, Professor Xavier Onrubia. He works at the Department of Anesthesiology, Critical Care and Pain Relief at Hospital Universitari Dr. Passet, Valencia, Spain. He is also an airway lead at his hospital. He is an EMS extended board member and the Spanish Council representative. Hola, Xavi. And also to join us, we will have to talk about tracheostomy. Hello. Hi, Xavi.
Hello.
To talk about the other two lectures about tracheostomy care and tracheostomy and laryngectomy airway emergencies, we will have Professor Brandon A. McCraff. He's a consultant in anesthesia and critical care at Manchester University NHS Foundation Trust, an honorary senior lecturer, a vast professor of anesthesia and airway management, a Royal College of Anesthesists Mackintosh Professor 2021. He's also the National Clinical Advisor for Tracheostomy for NHS England and NHS Improvement, and also the European lead for the Global Tracheostomy Collaborative. Hi, Brendan. Thank you for joining us. And also joining us as moderators of this webinar, from the other side of the Atlantic Ocean, I introduce you Dr. Paula Chiesa. She's an anesthesiologist. She works at University of Buenos Aires, Argentina. She's also an EMS extended board member and Argentina Council representative. Hi, Paula.
Hello, Anna. Thank you.
And nearby, close to me, we will have Professor Robert Greif, anesthesiologist from Bern University Hospital from Switzerland. He's also an EMS board member and the society's past president. Hi, Tino.
Hi.
And myself also, and Isabel Pereira. I'm joining all of you all the way from Portugal. Having this said, we would like to emphasize the importance of the webinar's theme, since we want to raise awareness for this kind of patients and also for the often unrecognized implications of airway management. Having this said, how will this webinar work? All of you that are attending from your homes and workplaces, if you want to ask some questions to our panelists, please, on the lower end of your screen, you have a Q&A button, so please press it and type down your questions that we will address afterwards to our speakers. Also, this webinar will be recorded and it will be available on the EMS membership area, as well as with some articles that both our speakers kindly sent to us. And regarding the certificates, they will be issued on demand. So if you want a certificate, please send an email to our secretariat. Those certificates will be free of charge for EMS members. And if you are a non-EMS member, you will have to pay the sum of 30 euros. So join EMS. Having this said, I would like to kick off with a survey to all of you. And we were wondering if you have faced an airway emergency in a tracheostomized patient. So that survey will pop up, so all of you can vote. So please vote. Have you faced an airway emergency in a tracheostomized patient? Yes or no? And we will have the results shortly. Okay, so 72% have faced an air emergency in a tracheostomized patient. Having this said, I would like to start our webinar with Professor Xavier Onrubia, and he will talk to us about what do we need to know about tracheostomies. So please, Xavi, the floor is yours.
Okay, can you see the screen?
Yes.
Yes, okay. Good evening, Ana Isabel, Tino and Paula. Thanks so much for inviting me to the lecture in this webinar. This is the title of that's my conflict of interest disclosure. So wait a moment. Okay. Some holes are stressing, but if the hole is or has to be placed in a neck of a patient, it can be a scary situation, especially for professionals not used to manage with them. This is a fear of neck access. Okay. So first thing we must know is what kind of hole we are facing. In the tracheostomized patient, the air entry can run through two different ways. However, in the laryngectomized patient, there is only one way for air. It is what we know as only neck breather. Therefore, oral or nasal routes are not feasible to ventilate this patient. Obvious, isn't it? Well, not so obvious, as these papers show. When medical students or residents were asked to solve oxygenation problems with these patients, more than 25% of participants did not know that tracheostomized patient could be orally intubated, and 25% choose that to attempt oral intubation or occlude the stomach to supplement oxygen in the laryngectomized patient. What's more, this behavior does not seem unusual, and oral intubation is attempted on laryngectomized patients more usually than expected.
So that's this next slide prompts up really a nice question that, Xavi, if I have a patient that needs a tracheostomy, what steps and stages should I address to prepare my patient for a tracheostomy? And what type of tracheostomy should my patient have? And how can I enhance the safety of this procedure? Okay,
thanks for the question, Anna. Based on the patient's clinical conditions and neck anatomy, we decide the most suitable technique for this patient. And then we establish an action protocol aimed to prepare the patient, the materials, and the team. In this sense, there are some common steps for all techniques that we must follow. As time to stop feeding, last dose of low molecular weight heparins, patient positioning, setting the ventilator parameters, preparing the drugs, and so on. Cervical hyperextension is essential for a better anatomic exposition, but we must bear in mind that location of the point of entry can undergo major changes in positioning. Following the same concept this paper described for the critical procedures, we can define 3 different steps to perform a trachea. We have first to identify the point of entry in the skin by several different modes. Then we will create an access to the trachea, either by surgical or percutaneous technique. And lastly, we will insert the trachea tube, usually loaded on an inserting device. Let's go to the surgical open technique. There are 4 important moments: skin incision, separating the 2 lobes of the thyroid gland, creation of a tracheal rolling window, and the trachea tube insertion. The skin incision can be vertical or horizontal. Neither one of these holds any technical superiority, and the incision should be tailored to a size sufficient to work in a comfortable way. The ergonomics and the role of participant, as well as the location of the different apparatus being used and the number of participants, are all important to ubicate. This is a sequence of an open tracheostomy. We find the tracheal rings once the thyroid gland have separated, as we see in the picture, in the last picture. So then we have to create the tracheal window. We have different approaches as preferred by each staff. Once the window is open, we can insert the tube loaded on a introducer. Well, for percutaneous tracheostomy, those are the father of percutaneous tracheostomy, those who invented the different devices to create a tracheostoma. All this procedure use a cannula over a needle to insert to enter in the trachea, and then insert a guidewire through which the dilator device will roll to be placed to make the tracheal hole to finally insert the tracheal tube. There are different methods to perform a percutaneous trachea with different concepts, all of them, on how to create the hole, like forceps, monodilator, the percuttwist concept, and so on. And but all of them are based on Seldinger techniques, all of them, to enter into the stoma and create, the stoma. All Seldinger technique, and each one of them to create the stoma. There are several papers comparing one method to another that have been published, but this one is a summary of all of them. The conclusion is that no method is better than the rest, and the selection depends on the team preferences, experience, clinical situation, availability of material, and so on. The ergonomics for a percutaneous trachea are different to the open technique and usually performed in the ICU. In this situation, the operator must have a clear view of the fiber optic bronchoscope screen and or the ultrasonic machine if is used. If the bronchoscope is used, it must be managed by a different operator who performs the trachea. You can see here the process of a percutaneous trachea. The bubbling syringe with saline indicates the entry of the cannula over the needle into the tracheal lumen, and then the guidewire is inserted. Second step is the creation of the stoma. In this picture, you can see the percuttwist device. Once this step has been completed, you only have to insert the tracheal tube loaded on an introducer. Once the tube is placed, you can check the correct location and finally connect the patient to the ventilator. So the dilemma is surgical or percutaneous technique. What is the better? The surgical technique is suitable for, suitable for all patients requiring a tracheostomy. However, the percutaneous tracheostomy, the percutaneous technique, offers some benefits compared with a surgical technique. On the other hand, as professionals have gained experience with the percutaneous technique, some of the past absolute contraindications become relative and sometimes even better indication. There are some meta-analyses that were performed at the beginning of this century, outlining the percutaneous technique, having a lower infection rate, a lesser minor bleeding, a more favorable scarring, being a quicker procedure, and being cost effective. In a more recent systematic review performed by a Cochrane library, they show that there is a high heterogeneity among all the studies that have been published, and significant percutaneous trachea seems that significantly, reduce the rate of wound infection and unfavorable scarring, but without any other better quality evidence for any other of the outcomes. So there are some elements to improve the safety while performing a percutaneous tracheostomy. Although techniques were first performed without a real view, the fiber bronchoscope has been used since the early beginnings, and it seems to decrease complications. However, one of the main problems with its use is the interference with the ventilation of the critical ill patient, as we have to take here a look of how the outer diameter of the bronchoscope fits with the inner diameter of the tracheal tube, resulting in a worrying decrease of the sectional area of the tube for a suitable ventilation. In the last decade, the use of ultrasounds to identify the point of entry and even more to guide all the procedure has widely spread. This paper shows the higher rate of first pass success and the appropriate midline entrance for US-guided tracheal puncture when compared with landmark palpation. So there are a lot of studies that compare effectiveness of both techniques to guide the percutaneous technique, comparing the use of bronchoscope with ultrasound use. And the final result of these studies is that ultrasound guide is a favorable alternative to the fiber optic guided percutaneous tracheostomy. However, one of the problem is getting skilled with the technique to perform a tracheostomy. As in this paper shows, the authors state that there is a long learning curve and at least 50 procedures are needed to perform the technique with an acceptable complication rate and procedure time. This table is a summary of advantages of each one of the techniques. Fiber optic allows for the view of all the process running on the tracheal lumen, detect the presence of bleeding and secretions, and we can measure the distance from the tracheal tube tip to the carina. On the other hand, ultrasounds allows us for assessment of all the anatomical structures that are lying under the skin until the tracheal lumen. It is a quicker technique. The operator can be the same for control and the execution of the procedure. And lastly, there is no interference with the ventilation.
Xavi, I have a question for you because, as you know, tracheostomy tubes come in all different shapes and sizes, and names and characteristics differ between manufacturers. So could you please give us some tips to help us all navigate in this sea of diversity?
Yeah, okay, this is really a complex world, as we can find cuffed or uncuffed tubes. They can be fenestrated or non-fenestrated. Tube length can be adjusted by means of a movable flange in some models. There are some tubes that have an inner cannula to make cleaning easier and practical. And especially for critical ill patients, some models incorporate a subglottic suction port. So you can choose whatever you want. But we have to bear in mind something. We have to be beware of the inner diameter and the outer diameter of the tubes. It can be different depending on the manufacturer. Let's see an example in this table. Size number 8 for the Portex is 8.5 millimeters, and for Chile tube is 7.6. However, the outer diameter in the Portex is 10.9, and outer diameter for Chile is 12.2. This we have to bear this in mind because all the holes doesn't fit with the outer diameters. Another thing, we can see some of the characteristics or some information about what kind of tube we have in the flange of the cannula of the tube. It's important to know that if we use an inner cannula, it decreases 1.1 to 1.5 millimeters the inner diameter of the tracheal tube. And finally, we have to know also that the 15 millimeters adapter is sometimes in the tube and sometimes is in the inner cannula. And also we have to bear in mind this. We have to control the balloon pressure. Too much can be deleterious, as the pressure can impair the microcirculation of the tracheal wall mucosa, resulting in injury for the mucosa. So no more than 25 millimeters. And finally, hopefully, not all holes will be stressful. Thank you very much.
Thank you, Xavi, for your presentation. So just a note to the audience, please type your questions that you want to address to the speakers on the Q&A section below and not in the chat. So we will address these questions that you want to ask Professor Xavier at the end of the webinar, after all speakers have made their lectures. Now, moving on, we will have Professor Brandon McGrath to do his first lecture about tracheostomy care. Please, thank you.
So thank you, first of all, to the Society for the invitation. Thank you to Anna, Paul, and Tino. Thank you also to Xavi for that really interesting talk. It's worrying to follow such a great talk, but I will do my best. I'm conscious that there are a lot of people from all over Europe listening, and I apologize that English is my only language. I'm from the north of England, and I'm already aware that all of my co-panelists can actually speak English better than I can. So I hope you can understand me. So I'm going to talk around tracheostomy care. I have a number of jobs to do with tracheostomy care in my country and beyond, none of which represent a significant conflict of interests for the purposes of this talk. Anything that I say you can find on the internet if you type tracheostomy into a search engine of your choice, and UK if you're outside the UK. You will find the National Tracheostomy Safety Project website, which is full of videos, resources, papers, publications, and things that will help staff and patients and their families. So I hope you find that useful. So what I'm going to cover in the next 15 minutes is why I think we all need to know a little bit about tracheostomies. I was very pleased to hear Xavi refer to them as trachees, as we do as well. The sort of problems you can have with tracheostomies, what do patients think about the problems they can have? Because it's important to think about what the patients think as well as what we worry about. Signpost you to some of the resources that are available for people to use. I'm going to talk about collaboration, the impact of our quality improvement programs. And I hope by the end of it, you're thinking, well, why aren't I doing this already? Because a lot of it is straightforward if you think about it. So we're going to come across tracheostomies in all sorts of locations, wherever you work, whether you work in operating theatres, intensive care units, on the wards, or in the communities. And they can present a number of problems depending on where you work. So the sort of problems that you might come across are basically because tracheostomies are usually required for patients who have trouble breathing or patients who have trouble coughing. And the nature of those interactions means that the sort of complex patients that we end up with tracheostomies often have organ failures, they require organ support, and they require a very multidisciplinary team to look after them. Doctors, nurses, speech therapists, physiotherapists, all sorts of different people from different specialties, from head and neck surgery, intensive care, anesthesia, medicine, respiratory medicine, and trying to coordinate this sort of team can lead to problems. Some of these problems are well publicized. Most of these reports are from the UK, some you will be familiar with, but some are international. And the reports all tend to come up with the same sort of themes. And an example here, you can see one detailed report in the United Kingdom looking at 2,500 cases. They found evidence of harm in about 1/4 of all intensive care patients and about 1/3 of all patients who are managed on our general wards. So the sort of themes that started to emerge from these data, when you look at them, is the themes were around education, around staffing, the provision of equipment in emergencies, the infrastructure that surrounds tracheostomy patients and the support that we can bring our patients, interventions that were completely lacking a focus on what the patient wanted. And a lot of the harms that were occurring are entirely preventable. And they're preventable if we think about them and put strategies in place to stop those things happening. So in the United Kingdom, what we did is we took the pieces of the jigsaw that are available out there. So what work individuals, groups and hospitals had done to try and solve some of these problems and to put those pieces together and come up with a project to improve the safety and then the quality of care. And if you go to our website, you'll find things like e-learning packages, which staff can access, get certificates to say they've completed them, covering some of the things that Xavi showed you in the previous lecture. There's some free manuals you can download. You've got to have a smartphone app nowadays, otherwise it's not a proper project, but we have an app with the videos and some of the resources that you can access. And we've also increasingly started to focus on not just what healthcare workers want, but on what patients want. And if we put the patient at the heart of trying to solve these problems, we can start to see things through their eyes. This is a man called Bob, who was our patient champion at my hospital for many years. And what the sort of problems Bob told us about were, well, he was worried a little bit about emergency care, but he assumed that in my hospital, all the staff knew what to do. What we were starting to think about was actually stop emergencies happening in the first place by preventing them, by basic care done well. But then what Bob cared about was high quality care. He assumed he would have safe care, but he wanted better care. And so that's the sort of thing that we started to shift our focus towards, about improving the quality of care. So the sort of things we started to do was to look around at the international literature that was available. And you can find all this fairly easily. But individual hospitals, teams and individuals had produced work looking at multidisciplinary team care, standardized protocols, education for staff, and then getting patient and family input. And what we did was to bring those ideas together into something called the Global Tracheostomy Collaborative. And we dropped that collaborative, that approach, into a number of hospitals around the world. And we've performed a number of quite detailed analyses now in the United Kingdom and in other hospitals around the world. And those sort of evaluations have allowed us to explore what sort of things work in what sort of environments. So the programme which we've just completed in the United Kingdom was called Improving Tracheostomy Care, funded by the Health Foundation and supported by our College of Anaesthetists. The aim was to improve the quality of care and the safety of care. And by doing that, we thought that it would have an impact on organisational efficiency. We also wanted to learn how to make changes, but that's a whole nother lecture in itself. We'll save that for another time. We had 20 very different sites up and down the United Kingdom, and I'm sure our health system is like yours, where we have big hospitals, small hospitals, children's hospitals, adult hospitals, and everything in between. We were also supported by this global network, and so whenever you're trying to improve care, you don't have to do it by yourself. There's people all around the world who've done this before, who are doing it, or who want to do it, and who may have expertise and improvements in different fields of tracheostomy care. And so we lean very heavily on other people's experiences. The drivers for change are summarized on these slides. So having a truly multidisciplinary approach, so everybody who needs to be involved is involved, not just doctors or nurses. Trying to standardize care. So within my hospital, we have 3 different intensive care units, and we were all doing slightly different things when it came to tracheostomy care. And so trying to bring all those things together makes it a lot easier to teach staff, to keep them supported, to keep them informed. Making sure that every doctor, nurse or provider who's going to meet somebody with a tracheostomy has been trained in managing emergencies and in providing safe care. And that's quite difficult to do, but it's important. Making sure that patients and families were actually genuinely involved in the improvement efforts, because there's no point making efforts to improve care if it's not relevant to the families. And using data. How do you know where you're starting, and how do you know where your interventions make any difference? You need data to drive those improvements. So the sort of things that we had were grouped into 3 themes around organizational interventions, quality improvements, and then things that would improve safety. We looked at those over time, and what we could do is rearrange those to see which of those interventions were easy to implement, which of those interventions we ran for the whole 3 years of our program, and which of those interventions were a little more difficult to implement. And the question I normally get asked is what sort of impact do those interventions have? And we spent a lot of time looking at the results from this program and trying to work out the impact of those different interventions. So we involved over 2,500 patients and about 1,500 staff in making those changes. And firstly, we looked at safety of care. And if you looked at the type of incidents that occurred at the beginning, in the middle, and at the end of the program, incidents occurred all the way through, and some incidents on the right-hand end of the screen still resulted in severe harm and death. But overall, incidents were detected earlier, they were managed better, and overall, we found that there was a reduction in the severity of incidents by about 50%, which is a lot. In terms of the quality of care, we focused very much on what patients asked us for. This is an example of what a patient might see when they wake up in hospital. They're confused, they don't know what's going on, they can't speak. And patients tell us it's frightening. They tell us that there's a big loss, and they tell us that part of them feels like it's gone. And what we did is that we used social media to send little videos like that to bedside staff and try and engage them in understanding the patient perspective. And what we found was by staff talking to patients and enabling them to talk, focusing on the things that are important to them, we were able to reduce anxiety significantly and depression significantly, maybe by about 50%. The results of the team had a very big impact as well on ventilator days, days in intensive care, days with tracheostomy in situ, and days in hospital. So overall, contributing to around a 20% reduction in these metrics for patient care. That translates into big money savings. So we saved about 33,000 British pounds per episode, which if every hospital in my country decided to do this program and saw the same results, we would save about 270 million pounds per year. Now, since we've left the European Union, I've got no idea how much that is in euros, but I suspect it's still quite a lot of money. And about the quality of care, well, when you ask patients what they want to eat, drink, talk, and get out of there faster. We had a rapid improvement in time to cuff deflation, down by a week overall. Rapid time to patients talking, huge increase in patients eating, because we were making staff realize that actually we could feed patients sooner. And it doesn't matter which patient you ask, they all tell us the same thing. They want to know, when can I eat, when can I talk, and when can I get out of here? So in terms of what we've discussed here, tracheostomy problems are common. Many of them are predictable, and I think we can all make improvements to our organisation, to the quality of care that we deliver, and that translates into improvements in the safety of care. So thank you for listening to part 1.
Yes, we can move on and carry on to the third and last lecture about tracheostomy and laryngectomy airway emergencies.
Okay, thank you. Well, I'll just keep talking then. So here's a video that I'd like you to think about. So if you walked into your hospital tomorrow and this lady was in front of you, would you know what to do? Would you know how to fix the problem? And if this happened on a ward or intensive care unit or in the operating theatre that you work in, could you be confident that your staff would know what to do? Would they know where the equipment is? And could you say to that patient, it's okay, we'll be able to safely look after you? Well, if you can't, hopefully I'm going to signpost you to a few resources that will be able to help. And certainly if you go to our website, again, you'll find lots of videos, step by step, taking you through how to manage these emergencies. I thought it was too difficult to show you on this website, on the webinar, sorry. And so I would direct you to the websites to show you. I'll also show you some papers which will be available on the EAMS webinar section for members afterwards. But this is an example of the sort of things you will find. So our patients present with airway problems, which staff may be able to recognize. The classic is that a patient, you won't be able to present a suction catheter. And of course, any sign of breathing distress can be due to an airway problem. So patients that desaturate, patients that have problems on ventilators. So these are examples of the sort of things that may alert you to the fact that there's a problem with the tracheostomy. And the approach then is to start to systematically work through the sort of problems that will kill the patients quickly. So we came up with some emergency management algorithms about 12 years ago now. The reference is there on the screen. And these have been adopted around the world. It's not the only way to manage an emergency, but it gives you a structured way that pretty much anybody can follow. So it focuses on calling for help. And in order to call for help, you need to have thought about who the help is, where they are, and how you're going to call them. Applying oxygen to the patient as quickly as you can, and then sequentially working down that algorithm, thinking about removing any potential problems like speaking valves or caps, removing the inner cannula, which will hopefully rapidly fix any blockage, trying to pass a suction catheter, and then thinking about more invasive strategies as you move down, which may involve removing the tube, reintubating the patient, or reinsertion of a tracheostomy tube. The lower down the algorithm you get, the more complicated things can be. And so that's why you need your help. These algorithms are paired with bedhead signs. So if it took 3 anesthesiologists 2 hours to put the tube in from the mouth, you need to know that before you take the tracheostomy tube out. And so rather than flick through big piles of notes or look on computer systems, these bedhead signs behind the bed will tell you what you need to know in an emergency.
And how about patients that have a laryngectomy and even pediatric patients? I know that you also addressed those specific situations. What are the main differences?
Yeah, thanks, Anna. So as Xavi explained, if you've had a laryngectomy, you no longer have an upper airway. And this can cause a lot of confusion. It can also cause confusion where people think it's a laryngectomy and forget they've got an upper airway. And so this can work both ways. Put a bedhead sign behind the patient saying, I have a laryngectomy, because of course the patient may not be able to tell you that, is really important. And so the approach is slightly different, focusing obviously only on the neck. And this can be life-saving. And I'm well aware, as I'm sure lots of people are, of disasters that have happened when patients with laryngectomies have been tried to be managed by their nose and mouth. The approach in children, again, is slightly different. The reasons children have tracheostomies are more because of airway abnormalities than in adults. So your typical patient on an adult intensive care unit will have a normal upper airway, and that's well worth using. Whereas with a child, they're more likely that the tracheostomy is the better airway. The tubes are smaller in children as well, and so they're more likely to get blocked or displaced. And so in a child, you would try and swap the tube as a first intervention, rather than working your way down towards swapping a tube with an adult approach. And again, the reference is on the screen and provided in the resources if you want to look at that in some more detail. And the sort of places where you can go, again, you can find all these things on the internet, the adult guidelines, pediatric guidelines, explaining how we developed the guidelines. And if you go to YouTube, you can find, we have nearly 60 videos now, which are a mixture of explanations and videos explaining how we can manage patients in the usual places that we work.
And of course, that if we think about reality nowadays with the COVID-19 pandemic, I was wondering how the approach to manage tracheostomies has changed. In which way?
Yeah, so we're all fed up of COVID, I'm sure, but COVID has had an impact on how we manage our patients. And tracheostomy management in particular has been influenced by COVID. In the UK, we've produced a number of resources, as I know other countries have, most of which are focused on the same sort of themes. And to answer your question, Anna, I'll just quickly address why we should do a tracheostomy, when we should do a tracheostomy, how we should do a tracheostomy, and then what you should do when you have performed a tracheostomy for a patient with COVID. So when you're thinking about tracheostomy care in COVID, we have this balance of protecting staff and benefits to the patient. And so initially, the reports that were coming out of China and other places and some of our European countries were suggesting that there was a real risk of harm for healthcare staff involved in tracheostomy insertion. And so, quite rightly, staff were worried and were very apprehensive about performing tracheostomies. And certainly, the longer you leave a tracheostomy, the less infectious a patient will be. However, that may not benefit the patient. And I think as we have been learning more about tracheostomies, I think we're thinking more about business as usual. And that's something that we've written about recently. When you think about the indications for tracheostomy, they're pretty much the same for a patient with COVID. We know that coronavirus will affect the larynx more than any other type of pneumonia. And so there may be additional reasons for a tracheostomy. And there is some evidence emerging from single centers that if you do your tracheostomies early in COVID patients, that may be beneficial, perhaps because we're shortening their prolonged intensive care stays, less sedation, less time on ventilators. But we're awaiting large-scale studies to help us with that. If you think about timing, most patients that come to hospital and end up on intensive care unit and get intubated, they're probably infectious, although that infection is reducing. So by the time we're thinking about putting a tracheostomy in, the risk to staff is probably relatively small. We don't know what the risk is, but it's probably small. And so I don't worry too much about when we do a tracheostomy, although we were worried 12 months ago about when we do a tracheostomy. So I think if you think the patient needs tracheostomy, do a tracheostomy. And as long as you have the right protection and the right systems in place, I wouldn't worry too much about the infection risks. They're certainly less infectious by the time you do a tracheostomy than the poor person who had to intubate them 10 or 14 days beforehand. Xavi outlined the different methods for tracheostomy insertion very nicely. For patients with COVID-19 disease, there are a few things we need to think about. Doing a tracheostomy on an intensive care unit is very convenient. It means you don't have to transfer them. And for someone like me who works on an ICU, we can decide to do a tracheostomy, and within an hour, we've done it. And trying to get them to theatre for that takes a lot longer than an hour. But positioning can be difficult. The intensive care beds are not ideal for surgery. The light and equipment is maybe not so good. Operator theatres are very familiar to surgeons if they are the people doing the tracheostomies. They have support assistance. We have a controlled environment. but we need to get the patients there, which exposes different staff and offers risks to the patients. In terms of technique, well, percutaneous techniques, as Xavi explained, are familiar to us. It's a smaller hole. There's less of a leak post-operatively, which can be relevant with COVID. But lots of our patients are anticoagulated. They still need airway manipulation. We need to use a bronchoscope. And there are concerns around leaking from the upper airway, although people have described various ways of trying to reduce that. Surgical techniques are obviously familiar to surgeons. They can manage bleeds probably better than we can percutaneously, but it's a bigger hole. You need a willing surgeon, and it usually needs a theatre. So I would suggest that what we should do is what works best in your environment with your teams. And for us, we have surgeons available to do the tracheostomies, and it saves me having to do it. And so we've been using surgeons to do our tracheostomies. In terms of what you do next, well, again, in the UK, we've produced resources and a national programme to explain and provide resources to all the different staff who've had to come and help manage patients with tracheostomies. And I'm sure the United Kingdom is not alone in having to bring in staff from other areas to help us manage this huge numbers of patients with tracheostomies. And so we've had to provide training to staff who don't normally look after patients. The principles are the same, but there are some slight modifications. So try to minimize the number of airway interventions, but remembering to keep the patient safe. Trying to minimize aerosols, but increasingly realizing that actually we still need to perform the investigations. We still need to actively manage our patients, not do nothing. A cuff-up strategy helps to reduce the amount of aerosols, but again, that probably denies the patient talking, maybe slows down their recovery. We tend to use what we would call dry circuits, so not with humidification, because you tend to have to change a circuit less often. But we need to keep this under review because dry circuits can cause problems with secretions. All of this is summarized in a number of papers. Again, we have some UK resources there, but we've commented on this with some international consensus guidance, which I think is as relevant today as it was when it was published back in May last year. And so I think we are getting more comfortable with tracheostomies in COVID, and the approach is pretty much what we would normally do, but recognizing that we have to be careful. So PPE for staff, but remembering that our patients are still worried, they're still anxious, and leaving them with their cuff inflated for prolonged periods of time with no one proactively looking after them is not good for the patients. So to summarize, it's business as usual, I think, for tracheostomy care, but be careful. Thank you for listening.
Thank you, Brandon, for your 2 presentations in a row, and you're not short of breath, so that's quite impressive. So having finished our lectures, we are open to questions from the audience. But I am curious, and I want to ask Brandon and Xavi, exactly what types of tracheostomies have you been doing at your hospital during COVID? We can start with you, Brandon.
Okay. So purely from a logistics point of view, the intensivists were busy at the start of COVID and the operating theatres were not. And so our head and neck surgeons very kindly offered to help by doing the bulk of tracheostomies. So normally 90% of intensive care tracheostomies are done by the intensive care doctors who are mostly anaesthetists in my country. But in COVID, about 70% of tracheostomies were done by surgeons. Over probably from October, November, we started doing percutaneous ones because we had a little bit more time and the surgeons got busy again. And so currently we're doing mostly surgical, but with some percutaneous.
Okay, thank you. And Xavi?
In my hospital, we perform basically all percutaneous tracheostomy. There are some performed by surgeons, the ENT department, but we are quite prone to perform percutaneous tracheostomy, and only for patients who probably will be more complicated to perform a percutaneous tracheostomy. Those we call the surgeons, but the other ones were performed by us. Probably as the operating theaters were closed, we have a more great implement of people in the ICU with can help that we are usually performing anesthesia, and so we can help to the usual staff being working on the ICU, and we have more people to perform percutaneous tracheostomy.
Okay, thank you. Paulo, Tino, do we have pertinent questions from the audience?
So there's a first question, maybe for both of you. If you have a laryngectomy patient and they need an intervention, do you use transcutaneous CO2 measurement during an intervention?
Transcutaneous.
I also was never thinking on this, but if you want to measure the CO2, are you using, because if they only have a monitored anesthesia care with oxygen over a mask on the tracheostomy?
So there are ways of connecting up a waveform capnograph to a laryngectomy stoma. If it's just a mask, you can just use the connector in the mask. There are masks available for that. If the patient is undergoing a more significant anesthetic, you can insert a tracheostomy tube or special, they're called Montadon tubes in the UK. They're like a hockey stick, we would say, like an L shape with a very small intratracheal part, which you can then connect up to an anesthetic circuit. Or of course, you can use a pediatric face mask or a supraglottic airway, like a laryngeal mask, applied to the skin, which you can then connect to a standard anesthetic machine with a waveform capnography. So I would encourage the use of waveform capnography, I think, because that's the only realistic way you're going to know that you have a patent airway and adequate ventilation.
Yes, I am agree with you, Brendan. Most what we have done mainly was to put a laryngeal mask in order to connect the capnography.
Paula.
Okay.
Yes, we have a next question about percutaneous tracheostomy. Is it not safer to use ultrasound first to locate the thyroid and the puncture site, and then move to fiber optic for the percutaneous procedure?
Yeah.
Dr. McGrath.
Okay, McGrath.
Oh, I wanted to hear what Xavi was going to say. So I have difficulty trying to fit a percutaneous insertion kit and an ultrasound probe in the same time. So I usually would scan first to look for vessels and to check everything's where I think it should be, and then move the ultrasound machine away and never use it again, and then perform the percutaneous technique with the bronchoscope. I have seen people try and do it with ultrasound. You need a very small footprint on the ultrasound probe, and I find it too hard.
Yeah, it's the same for me. We usually perform first in some patients ultrasound view of vessels of the thyroid gland, and where to have the puncture. But it's certain that you need a very small probe because some patients it's very difficult to see a good image in order to work. And you have to be quite experienced in order to manage. Before ultrasound, we use the bronchoscope light in order to see against the skin if there is some important vessel, but it's more more useful the ultrasound. I think it's a very good device in order to perform, to see what are you going to do before, because the blinded part of the technique is what you do since the skin to the trachea. This is the only thing you cannot see anything with the bronchoscope, and sometimes you can have problems there.
There's another question for an emergency situation when there's no time and it's not clear which cannula you should use. What the question is, what is the best option now? Maybe one of you.
So I think I understand the question as, if you have an emergency, maybe you can't intubate, can't oxygenate, what should you do? I don't think a tracheostomy is an emergency procedure. And there have been a number of problems because people have spent a long time trying to perform a tracheostomy in an airway emergency. And the approach should be an emergency cricothyroidotomy, which is usually a scalpel bougie tube technique. Having said that, I mean, I have done an emergency tracheostomy, and I know others have. I think the default should be, and the teaching should be, it's a cricothyroidotomy first. There may be, you know, I'm sure there'll be plenty of people on the webinar say, oh, well, in this situation, a tracheostomy. If you think a tracheostomy is the best thing, and in your hands, you can do it as quickly as a cricothyroidotomy, that's fine. Most people can't, and a tracheostomy will take significantly longer than an emergency cricothyroidotomy. So I think I would recommend cricothyroidotomy first as an emergency.
Yes, I completely agree. Cricothyroidotomy has some advantages with respect to the tracheotomy, because it's a technique easier to learn for all physicians. To learn how to perform a tracheostomy, probably you have to be more experienced. The crico is an area that usually has not vessels, and you can insert here a scalpel without this feeling of if it is bleeding. I am very afraid to do things there. No, so I think that crico is the first thing. That what we try to do is to oxygenate patients, and then when we can oxygenate this patient, we can think about performing then a tracheostomy. But a crico can be used for some hours. No, it's not only a moment.
And now to the next question from the audience. What kind of anesthesia do you typically use for bedside percutaneous tracheostomy? Analgesics, hypnotics, or muscle relaxants?
Shall I answer that? Oh, go on, Javi.
Okay, no, it doesn't matter. Well, in the ICU, usually patients are with some sedative drug. So we increase the dose. That is usually if we are in the process of weaning the patient. And I think that the most important is that the patient has been with a neuromuscular block in order not to cough, and it is easier to perform the procedure. I think that is the most important. And analgesia, with the sedative, you can have more or less the patient in good condition. Sometimes we put some kind of opioid in order to perform only the procedure. I am not. I don't like to put any local anesthesia in the skin unless the patient is awake. But I don't like to put local anesthesia. It is not good to palpate the tissues or something like that. So I prefer the patient is asleep only to increment or put some kind of sedative or opioid, and of course a neuromuscular block.
Yeah, I would totally agree. I think probably the most important is the neuromuscular block, and then if they're already on the intensive care unit, whatever they're attached to. If they're in theatre, the only thing I would suggest is not using volatile anesthesia. because the poor operator usually gets it in the face. And if, you know, I've done it with a few surgeons and forgotten, and they've sometimes complain, sometimes they don't, and I feel bad. I have a slightly different approach to Xavi in that I do use local anesthetic, but I don't use it for its anesthesia properties. I use some adrenaline in there for vasoconstriction. That's the only reason to use it, which may or may not help, but positioning the patient a little bit head up, it probably has more effect. But yes, we have a very similar approach.
Okay, another question. Do you prefer sutures or a fixation band for the initial tracheostomy fixation?
I usually don't use sutures, and we use suture bands, and it's certain that we have no problem in my department with the cannulation of a patient by coughing. So I don't like to put more sutures in the neck, but this is my experience. I probably other people can be different, but my experience is that patients have not been decannulated only by bands. But you have to take care of that. They are not. They cannot be loose.
So I think there is no right answer to this question. And as Xavi says, you will have people saying, I always do this and I never do that. We are not very good at keeping tracheostomies in place, or as good as we should be. The perfect tracheostomy holder doesn't exist. I think that the worst thing that can happen in the first few days after percutaneous tracheostomy is it can fall out. So I stitch mine in. But the stitches, you have to remember to take them out and you have to go back and check. And I am certainly aware that if the tracheostomy tube gets blocked and you've stitched it in, you've created another problem that you need to fix. But if you have stitch cutters at the bedside, not so much a problem. But it depends where you work. And as Xavi says, if in your hospital, this approach works really well, don't change. But in mine, I worry that the tube will come out, so I stitch it in.
There's the next question. It's a really hard learning curve, about 50 times. What time did it take you to get to this technique safely?
Well, I think that you have to be interested on the procedure in order to do it in a good manner. So you can try to perform simulation in mannequins in order to get a skill with handling with all the devices. It's important to keep in mind all the process of the tracheostomy. How are you going to do that? And then what I do with the residents is I invite him to see videos in the internet in order to know how people can do that. And then they have a process that they perform the tracheostomy with one of the staff senior. And I think that in 5 percutaneous tracheostomy, they are able to be one only supervised. No, not very much difficult learning curve.
Yeah, I would totally agree with that. It's a useful skill to be able to needle somebody's neck, and so exposing lots of people, lots of trainees to the skill is useful. But I think more recently we've realised that actually not everybody needs to be able to insert percutaneous tracheostomy. So even amongst, say, the consultants on our ICU, there are some people who don't do it, which means we can concentrate the expertise. As Xavi says, there are plenty of courses, cadaveric or animal workshops or simulated workshops where you can learn the skills and the basic stuff, but then supervised practice is really important. But I think what we realize is actually not everybody needs to insert tracheostomies. And so condensing that pool of experience will help to make sure that you generate those numbers required to be competent.
Because of sake of time, and we like to finish on time, we close the Q&A session and come to the final statements of the speakers. Anna Isabel.
So I would like, thank you, Tino. I would like to ask Xavi and Brendan to give us in 1 minute their take-home message from this webinar. So please, Xavi.
Yes, those are my take-home messages. Laryngectomy means only neck breathing. Do not try other way. Team discussion to choose the proper technique for each patient, individualized. Use checklists for adequate staff material and patient preparation. The use of security adjuncts as ultrasound and fiber optic improve the percutaneous tracheostomy outcomes. All tracheal tubes are not the same. Check inner and outer diameter for a suitable use.
And so my take-home messages are that the problems are common and they're predictable. Talk to your patients, find out what's important to them, because the problems that they have will be very different to the problems that you think you have. And you can make improvements to your organization, the way you look after your patients, to the quality of care that you deliver, and that will impact on the safety of the care that the whole team delivers. And as Xavi's already said, a tracheostomy is just another airway. We need to plan, rehearse, and prepare how we're going to manage any problems that arise, making sure you involve the whole team, everybody that will be looking after that patient, and so that all staff can keep our patients safe. Oh, I've got another slide. So understand what works well in your hospital is really important. There's no point you listening to what I say and saying, well, we can't do that where I work. Do what works well in your hospital. Understand the problems. Find the leaders to fix the problems. And they may not be doctors. Anyone can step up and solve these problems. Collect some data, and I would recommend that you look at the Global Tracheostomy Collaborative, because it's all there on a plate for you. Thank you.
Thank you. And after this wonderful webinar, we have a last survey to do to all of you that are participating. And our last question is, do you feel confident managing tracheostomy and laryngectomy airway emergencies? Yes or no? We'll have our results briefly. While we are waiting for the results, I think we have, yes, it's pretty similar. So everyone, it's 72% confident managing tracheostomy and laryngectomy airway emergencies. So with this webinar, we addressed and raised awareness for these patients, the tracheostomized patients. I hope you have all enjoyed our webinar. If you have any other questions, suggestions, etc., please send an email to our secretariat. We are more than happy to answer to all of you and to listen to what you want us to address in our future EMS webinars. Please remember, the certificates are only issued on demand. So if you want a certificate, contact our secretariat. If you want to see again this wonderful webinar, again, access to the EMS membership area. If you're not an EMS member, please be one. So please take all good care, stay safe and sound, and we hope to see you again in our future webinar. So in the name of the EMS and everyone, thank you all, and thank you to our speakers for having this time to address this webinar. Thank you, Brandon. Thank you, Xavi. Thank you, Tino. Thank you, Paula. Thank you all. Stay safe and take good care.
Thank you.
Thanks.
Bye-bye.
Bye.
Thank you. Goodbye.